This conference will now be recorded.
Thank you, Rondi, and I had to wait till she made that little announcement before. I didn't want to do it in the middle. Hi, everybody, and welcome to part 2. This is going to be a little different than we did last time. For a minute here, we're going to go through the rest of the regs that we didn't do last time, and then let's get into a little bit of a tabletop on flu, and I'll explain why, and then the third part of the hour will be the after action report, which you will be wanting to do once this pandemic is past us. And boy, we can't wait for that. Before I even begin, let me just thank you for what you do out there every day. It's so important, and we as a nation appreciate what our rural partners are doing out there. Okay, so let's roll. So training and testing is this part of the deal, and obviously what we train for we succeed in, and that's called muscle memory. So you automatically do it. You don't pick up a fire extinguisher the first time in your life on the day of a fire. Hopefully you've handled one before and you know how to operate it. So that's what this is all about. So the EP training requirements are initial training to all new and existing employee staff, contracted staff, and volunteers if you have those in your clinic. Training is consistent with their expected roles. Training occurs at least every 2 years, and it's documented and demonstrates knowledge of your EP procedures. So the testing is divided. It used to be 2 a year. Now it's not every 2 years. It's 1 a year. It really isn't quite clear in the regs, but if you read the guidance, this is what they're expecting, CMS. So year 1 is an exercise, let's say 2020. So it's either a full-scale exercise that's community-based, or if that's unavailable, we have evidence of the attempt to do that, or an actual activation of the emergency plan, which exempts the clinic from the above exercise for 1 year. And boy, aren't you all in the middle of it right now. So we're in year 1, let's call it, and we have an actual event. So we need to document that, and we'll talk about that. So if that's the case for this year, then next year you have a choice to do a second full-scale exercise, hopefully not an event, that's community-based or individual facility-based, or a tabletop exercise. And that certainly would be acceptable based on this as an event, because this is an active event. We have actually activated our emergency preparedness plans. The tabletop is a narrated, clinically relevant emergency scenario with a set of problems designed to challenge your EP plan. What we see most often is that number 3, the analysis is missing. That is a critical part and would be a deficiency if you have a survey and you didn't analyze this event, your full-scale exercise, or your tabletop. So you must analyze your response to and maintain documentation of all drills, exercises, tabletops, events, and revise your emergency plan as needed. So operations-based exercise, and the hint there is really important. People ask me, what does that mean? That means we get up and move. We're not sitting around the conference table discussing what might happen. Okay? So exercise involves opening up your communication plan and moving something or someone. Involves personnel, deployment of resources and personnel are more complex than discussion-based types, obviously. Require execution of plans, policies, agreements, and procedures, clarify roles and responsibilities, and improve individual and team performances, and includes drills both functional and full-scale. Discussion-based exercises, or otherwise commonly known as tabletop, provide a forum for discussing or developing plans, agreements, training, and procedures, are generally less complicated than operations typed, typically focus on strategic, policy-oriented issues, and include seminars, workshops, tabletops, games, and do not involve any deployment of your resources. This is the infamous AAR, the After Action Report. If you were to Google CMS After Action Report, this will pop up, and as well as a set of instructions on how to complete it. It is not a requirement that you use this form, but I will tell you that the form will draw out the necessary information you need to have in a good after action report. So it's good, if nothing else, for its questions. So what does CMS say about survey procedures for training and testing? Number 1, they tell the surveyors, and this is both state or AOs like us, ask to see documentation of your tabletop or full-scale exercise, which may include, but not limited to, the exercise plan, the AAR, and the additional documentation used by the RHC to support the exercise. Number 2, ask to see the documentation of the clinic's efforts to identify a full-scale community-based exercise if you didn't participate in one. And so that could be a couple sentences in a paragraph in your binder that says, hey, we called the state of Oregon, we called FEMA, we called, and we couldn't get an active drill going, so here's what we did. And you just have names and dates to document that you couldn't get it done should that happen next year. Number 3, request documentation for the RHC's analysis. Again, there's that analysis and response on how you updated your plan. I will say this, even though you are going to do an after-action report this year, everyone should be evaluating their emergency preparedness plan this year because things changed. What didn't we have in there that we needed? What have we found out that we stressed in our system? And God knows there's a lot of things. Now, for integrated healthcare systems, this comes up under 491.12, I think it's 6, something like that. I don't have the number right here handy. This is if you're part of a healthcare system consisting of multiple separately certified healthcare facilities. So you're part of a large healthcare system, and you want to have a unified and integrated emergency preparedness program, which is awesome. That's quite acceptable. You may choose to participate in the healthcare system's coordinated emergency preparedness program. If you do that, okay, it's a much higher level of documentation. And watch this word all. If you as a clinic decide to participate in your integrated healthcare systems, you will do all of the following. Demonstrate that each separately certified facility, let's say clinic, within the system actively participated in the development of the unified and integrated emergency preparedness program. So they've got 5 clinics. Every one of them had a hand in the meetings, in the development of this program. And so that's where this higher level of documentation comes in. Must be developed and maintained in a manner that takes into account each separately certified facility's unique circumstances, patient population, services offered. You may have a pediatric clinic, you may have a women's health clinic, you may have a regular rural health clinic, but what is it that's unique about yours that needs to be taken into account? And then demonstrate that each facility is capable of actively using the Integrated Emergency Preparedness Program. That would mean your staff would generally know what's going on in the hospital emergency preparedness program. They would have been briefed on it. They can answer questions on it. And again, there's that high level of documentation. Now, number 4, include a unified and integrated emergency preparedness plan that meets the requirements of A234. That you can refer back to that later. But it's what must be found in an emergency preparedness plan. Here's the real kicker. Every clinic within the healthcare system must have a documented community-based risk assessment using an all hazards approach. This is the most commonly missed piece when we integrate into a healthcare system's emergency preparedness plan. Your clinic, even in the basement of the hospital building, must have its own risk assessment. It's the same things for weather, let's say, but within the clinic, what are the things that could hit your clinic right now that may not be hitting the hospital? How about loss of a provider? How about active shooter? The COVID-19 is hitting everybody, top to bottom, so that wouldn't really count because it's going to be both sides of that fence. And then 2, a documented individually facility-based risk assessment for each separately certified facility. What that means is it's got its own billing number. It is a unique entity. It's not a part of the system in terms of how CMS looks at this. All right, that's the important piece because we missed that. And then include integrated policies and procedures, and that would mean the clinic's name is rolled into that hospital plan by name because it is a unique entity and it's part of that hospital plan. So CMS says verify whether or not the facility has opted in. Okay, verify that by asking to see documentation of its inclusion into the program. We're looking for training logs, we're looking for minutes of the meetings where clinic personnel, and it can just be the manager, that's fine, are involved in that hospital planning. And then ask to see documentation that verifies that the facility within the system was actively involved in the development of that emergency preparedness program. Ask to see documentation that the facility was actively involved in the biennial reviews of the program coming up soon. Ask to see copies of the entire integrated and unified emergency preparedness program and all required components. This is a lot. You're going to have to show the surveyor this if you've opted into the hospital plan. Ask facility leadership to describe how the unified and integrated program is updated based on changes within the healthcare system. That's a big question for me to stand and ask a clinic manager, and that is a tough one to get an answer to. So I say it for what it's worth. Yes, you should do drills with them, but sometimes it may be easier to have your own emergency preparedness plan. It's one whole lot simpler, but again, it is your choice and it's certainly allowed. So here's what we see. Having EP plan, but not training the staff. And you can say you trained them, but if there's no documentation of that, it didn't happen. You know the old adage, if it's not written down, it didn't happen. So we look for training logs. We trained today on this. Here's a list of people that were there. Omitting required contact information. I mentioned that last time. That communication plan has to have the name of everybody that works in that clinic. Lacking the all hazards vulnerability assessment. And then provider-based clinics stating they're part of the big system, but not meeting that higher level of documentation. And we do see that. We do see that on survey. Outpatient providers are not required to have policies and procedures for the provision of subsistence needs. That is a hospital regulation. A clinic does not have to have that. What that means in a hospital is you must have the ability to have food, blankets, water for X amount of days, and there's a regulation on that for the hospitals. Clinics are not required to have that. You still must have a policy procedure detailing how your refrigerated medications will be handled during or after disasters that disrupt electrical power. And I go back to the same old comment I made before. It's 6 o'clock Friday night and the power goes out. You don't have hours again till Monday. The power comes on sometime Sunday afternoon. By the time you get in, the temp's in the right range. How do you know those drugs are safe? If you cannot answer that question, you need a different system. You need a system that alerts you, that somebody knows that the power's out. You can go down and move those, or you're on a grid of somebody that's got a generator and you can hook into that, something like that, so you can get generator coverage for your refrigerators. The RHC procedure may be to evacuate staff and patients when safe to do so, to close the clinic and notify staff's patients that the clinic is closed till further notice. I put that there because we got a lot of questions about that with Hurricane Harvey, where they in Houston, where the storm was so severe that they literally, the town was flooded and they had to close the clinic, nobody was coming out anyway, and go to the hospital literally to staff the hospital with the clinic personnel. So as long as you've posted it, you put something on your machine, if the phone's machine is working, if you can do social media, some way to tell your patients. Right now we have actual clinics that are closed during the COVID-19 emergency. And that's acceptable. We just have to notify people that we're not there, notify our patients where to go for care during this emergency, because either our numbers are so low right now, we've combined some clinics and closed one, or because we've made different arrangements for a variety of reasons. I have one clinic with one provider who is COVID positive, so that clinic is closed. There's not anything we can do about that right now. It's just one of those things. Lack of a provider in a normal situation may be a good thing, and you have a plan for somebody else to fill in, but right now there may not be somebody else. So these are the burden 3 changes that happened last November. It's still not even 6 months from that, so I like to keep those in. And that is that you used to have to do 2 a year and you do not any longer. You must still do additional training if your plan is updated, and it very well may be this year. And they've eliminated the requirement that you document efforts to contact local, state, regional, tribal, federal. You just have to have their name and numbers there. You don't have to document that you tried to call them and they didn't call you back. None of that. Facilities will still be required to include a process for cooperation with those people as part of your program, but you'll have that in your plan, that you've written that paragraph. CMS has revised the requirement that only one testing exercise is required annually, which may be either the community-based full scale, individual facility-based, or the tabletop. Okay, so these are some resources. These are all good. These are not active links at CMS.GOV. A wonderful resource on emergency preparedness, a lot there now. Right now, actually probably the best one right now is the CDC. Their COVID website is excellent and updated every day. We check it every day at this point. There's more CMS.gov. Now, the FAQs are wonderful. There's also COVID FAQs right now, but the CMS FAQs and emergency preparedness are good. Bear this in mind. They're all lumped in there together. So you may be reading something that does not apply to the rural health clinic per se. It only applies to a hospital, to critical access, to a dialysis center, whatever. They're all lumped together. They did not call them out separately. So just something to be aware of. FEMA obviously is a busy site right now too, and they've got drills that you can use there, tabletops, exercises, all kinds of information for you to dwell on. CERT is Community Emergency Response Team. This is an organization that does drills within the state. I wanted to just show you, here you go. This is CERT Oregon, and I just took a picture of their page this morning. Community emergency in Oregon, in Benton, you know these places better than I, Lincoln County, Oregon, some phone numbers. They do drills throughout the year. You can get in on a drill that would save you the work of having to put one together. Their basic CERT is 45 classes in 6 counties. That's a lot throughout the state. And I don't know how many counties you have. 6 seems like an awfully low number. But anyway, you see information here. Let me just flip back. I want to go back to where I was on the CERT. CERT is a great organization. You can volunteer to be trained by CERT. You can tie in with them on exercises. But it's in every state in the nation. And they, of course, their role is to prepare for, respond to, and recover from disasters such as we're in right now. Cal Hospital Prepare, if you're still and you shouldn't be, we're way into this now, but if you are way back where we're trying to figure out how to put this thing together, this is an excellent site. They have all kinds of tools that you can borrow. There's no need to reinvent the wheel. It's all out there. And matter of fact, most of the rest of this presentation today is the compilation of 3 different people's presentations. Why do it over again? As per Tracy, matter of fact, just today, and I haven't even looked at it yet, they came out with COVID-19 response guidance. This is a contractor that works for HHS, and that's all they do is emergency response, emergency preparedness. That is in a phenomenal website. Lots of good information there. This is CIDRAP. This is Columbia University. They also have a great toolkit. I like that one for the toolkit. So if you're looking for upgrading and changing things, there's lots of resources. And of course, these are some that you more commonly know in rural health clinics. Rhonda Yan, of course, is with NOSOR, and they have guidance, NRHA, and National Association of Rural Health Clinics, HRSA, of course, in the RHI Hub. Actually, they're having a COVID information webinar. I think it's tomorrow. If you could check me on that, but there's a lot of webinars right now going on around the country. Okay, so before I move into a quick tabletop, are there any questions, Rhonda Yan?
No, there are no questions at this time.
Okay, so that was basic regulations. So I thought it would be helpful if we put together a tabletop, and you can take every slide here and put it into, type it up and put it into a book, present it at a meeting in your clinic, and you have a tabletop exercise, and it counts. We'll talk about the elements that you need to make that count for survey as we go. So this exercise is being conducted via webinar, such as we're doing. However, you are expected to discuss this with your facilities. You're all clinic managers and staff. You're going to go back and do a training log. When things settle down and you need to do an exercise, you take this information, you put them around a table, provide lunch perhaps, and you come up with this. A scenario would be presented in a second, followed by related questions. Should take notes. These notes will be used to develop your after-action report / improvement plan documentation. The more engaged you are during this exercise, the better your final product will be. And I will say, you're all engaged in COVID-19 right now. Make notes. Put a little spot on your computer or on a pad of paper in a drawer. Every time you think of something, jot it down. When this is all over, and it seems it's going to be a few months yet, I hope it's only a few months, we will forget what we wanted to write. I actually started my own today on things that I'd like to see go back, not change, not go back to the way they were, such as CMS is pushing our initial surveys through right now and getting billing numbers very quickly. This is wonderful. wonderful news for the clinics that are coming to the program right now. We want that to continue later. They've shown us that they can do it quickly, so we don't want to have to wait later. That's the kind of thing I'm talking about. Things that you're seeing right now that we can't deal with right at the minute. So these are the objectives of our tabletop. To reveal the planning weaknesses in our emergency preparedness plan and its standard operating procedures, or to test and validate recently changed procedures. To identify current capabilities, to improve the coordination between and among various response personnel, to identify deficiencies or validate training on the critical elements of emergency response, and to increase the general awareness and understanding of a potential hazard. For this purpose, I've chosen influenza. Okay, this is a tabletop. I was going to do COVID, but you're living COVID right now. We'll do the after action for COVID. For the tabletop here, let's use the flu. The flu's been with us many years, and it's likely to be with us many years. So as part of your tabletop write-up, you'll have those objectives we just talked about, and then you're going to put a little bit about the disease. So it is a contagious respiratory disease, as you know, spread mainly by droplets, cough, sneeze, talking, less often by touching a surface. The time of exposure to signs of symptoms averages about 2 days, but it may be infectious a day before symptoms develop. So flu spreads like rocket fire. Fortunately, we have a vaccination against flu, but many times that's the one that was given to us in September doesn't work this year, and you know about that. So you're going to have a write-up about what flu is, a contagious respiratory illness caused by the influenza virus that infects the nose, throat, and sometimes the lungs, can cause mild to severe illness, and at times can lead to death, as we know. More people have died of flu this year than COVID. The best way to prevent flu is by getting a flu vaccine each year. In the U.S., flu season occurs in the fall and the winter. While influenza viruses circulate year-round, most of the time flu activity peaks between December and February, but activity can last as late as May. Most experts believe that flu viruses spread mainly by tiny droplets made when people with flu cough, sneeze, or talk. These droplets can land in the mouth or noses of people who are nearby. Less often, a person gets flu by touching the surface. And I'll skip to the last one. Children are most likely to get sick from flu, and that people 65 or older are least likely to get sick from flu, which I found fascinating. And I would expect that somebody would challenge that statement, and if I had time, I might even have looked that up, but I did not get to that. The tabletop, the time when a person is exposed and infected with follow-up to when symptoms occur is about 2 days, but it can range from 1 to 4. You may be able to spread flu to someone else before you know you're sick. People with flu are most contagious in the first 3 to 4 days after their illness begins. Some otherwise healthy adults may be able to infect others beginning 1 day before symptoms, and some people, especially young children and with those with weakened immune systems, might be able to infect others even for a longer time. So what we're doing for our tabletop is we're providing some background. We'll type this up. We'll put it in our tabletop drill folder or section of our binder. We want some statistics in there, 37.4 million to 42.9 million flu illnesses per year. Actually, that's not even a year. That's it is, October of 18 through May of 19. 531,000 to 647 hospitalizations, 17.3 million to 20 million, the range of medical visits, and then 36,400 to 61,000 flu deaths in that period of time. So each year, CDC estimates the burden of influenza in the U.S. CDC uses modeling to estimate the number of influenza illnesses, medical visits, flu-associated hospitalizations, flu-associated deaths that occur in a given region, in a given season. And I would not have been able to put this together as I think about it with the COVID. We don't have enough information yet. So here's our exercise, and this is how it goes at a tabletop. It's now mid-September, and the CDC is expecting an active flu season. Local media outlets and health departments are promoting the flu vaccine, and you see that, and you do that in your clinics, and many of you do flu clinics. What kind of steps does your facility take leading into flu season? And this is a discussion that's going to occur around the table. And what are we doing? Are we having a flu clinic? Do we have signs up? Do we have masks available? Do we have alcohol-based hand rubs plentiful around the clinic? What should you be doing but are not doing? Again, these are the kind of things you're going to have in that discussion. Now, news outlets are reporting, a local elementary school is reporting that 13% of the student population has the flu. Administrators are dismissing classes early to thoroughly clean the facility, and calls are coming to your facility from concerned patients and family members. They want to know what to do. They need your help. And this is where, again, this is the next step in it. What is our discussion look like? What type of information do you need from your local state public health entity? What are you doing to educate your staff, patients, family members? And what other actions are you taking at this point? That's your discussion. And you would have fill in the blanks under each of those questions for your write-up. Next step, a second school closes. More than 1/3 of the high school students report they had the flu or flu-like symptoms. Elementary students on the same campus were also complaining of flu-like symptoms. The school plans on remaining closed the remainder of the week to conduct a thorough cleaning and to avoid the spread of the virus. 5% of your staff have notified you they're not showing up for work today. They're either sick or their child is sick, which of course we always have to remember, and their calls keep coming into your clinic. So you've got to take this next piece of information and figure, okay, are we able to continue operations with a staff reduction of 5%? How are we going to do that? What measures are we going to take to make that work? We still need to have our patients to see. What measures are in place to protect our patients and the staff from the virus? Are we wiping down doorknobs, everything anybody touches after a patient leaves? What suggestions can you make to patients to remain healthy? And what protocols are you activating for your patients and staff, wearing masks, sick area, etc.? We have clinics right now that are using extra space. And if you didn't hear it today, CMS has allowed that if you have a need to use a different room, a different part of your building, a part of the hospital, for a part of your clinic's patients, that is 100% acceptable on the waiver that was announced today. We had already been approving that. That's good sense for people that need to do that, but that is now officially approved by CMS for the current time. Update. The local health department is encouraging the public to get their flu vaccine and if experiencing flu-like symptoms, to stay home, avoid contact with other people except to get medical care. The state health department and Department of Education closed all schools and daycare centers for the remainder of the week to reduce the spread of the virus. Now we've got 15% of your staff have notified you they're not coming to work. Some are sick, some have sick children, some don't want to risk getting sick. That's an unusual one I don't hear very often in healthcare. Patients are insisting on receiving the flu vaccine and antiviral medications. And that's, of course, your provider's decision where to go with that. So now the discussion says, are we able to continue operations with a staff reduction of 15%? If so, how are we going to do that? And I would say some of you are even seeing that now. How are staff members who have potentially been exposed to the flu treated? Are they told to stay home? Are they made to wear a mask? How are those who elect to stay home out of fear treated? That's something you need in your HR policy. Are you able to provide flu vaccine to all patients? What decisions are made about continuing operations and who makes these decisions? These are all the questions you're going to discuss at your tabletop exercise, and they're going to result in adjustments to your emergency plan. Update, 1 week later, things are now getting better. Only 3% of your staff is unable to come to work, and the calls have decreased. We're past the, I guess I should use the word, we flattened the curve. We're on the other side. What are your sick leave and general leave policies, and how does an event like this impact these policies? Were you able to continue to provide needed services with a lower number of staff? What can you do to maintain staffing levels during an event like this? And what kind of supplies do you need to reorder? If your normal supplier is low, what other supplier could you use? And that's the basic exercise and how we do a tabletop exercise if you haven't done one. If you're fortunate enough to get somebody to lead one, that's wonderful, but for the most part, we're seeing that it's the clinic manager putting this together to do an exercise like that. So after the exercise is over, we're going to have sometimes it's the same team, but sometimes it's the management team which does the evaluation, the after action report, the hot wash, many different names of that those who are familiar with this kind of activity call it. What strengths in your workplace emergency plans did this exercise identify? We had it aced. We had it together. We had a process. It worked, and we're in good shape. Or what weaknesses in your workplace emergency plan did this exercise expose? And it's typically a combination of both. We were really strong in this point. We weren't so good in this one, kind of thing. What unanticipated issues arose during the exercise? What are you seeing now that is surprising to you? What gaps were identified? What are some of the high priority issues that should be addressed immediately before something else happens? And what are some new ideas and recommendations for improvement? These are all good questions for your analysis. And if you follow this direction and use these 6 or even others, you'll have a good report and you won't have any issue. You'll have learned from it, of course. And most importantly, you won't have any problem with survey. Now that you've completed your tabletop, consider these additional actions. Compile all notes taken during this exercise. Gather your staff at the respective facility to discuss gaps in your plan. So if you had the exercise and then the management went away and wrote this plan up, gather with them one more time so that they can understand what we learned, what we're changing, what's new and different. Draft an after-action report on the results. Assign leads within the organization to address the gaps. So we're going to have assignments on who's going to work on this, who's going to work on that. Now, many of our clinics are very small and we don't have that kind of luxury, so we all do it. We all do all of it. Or communicate the steps you're taking to your entire organization. That's really critically important. Okay, so that is the way a tabletop exercise goes. I will say to you, we just had a tabletop exercise. We didn't fill in all the blanks, but if you take all those points, type them up, you will have a tabletop exercise for the next time when you need one. Right now, we're in a COVID event, obviously. I put this website here because this is you have a really good one in the state of Oregon, and so should be an active link for you to go to that if you don't already know about that. So this is now the after action report that I would trust that you would all be doing in the months to come. And so we're going to put the clinic name there. We're going to call the event name COVID Outbreak 2020, COVID-19. The beginning date is really very curious. It could be March 9th. That's when it began really for me. I was in a clinic in Pennsylvania. Actually, it was right here in my own state, so I don't do too many surveys myself anymore. But it was just the very beginning stages of it when I was up there in central Pennsylvania. Restaurants were still open, but that following Monday, everything closed. It was that quick. So I put an end date here of May 10th. I'm sure I'm being wishful thinking there. I hope it's not June 10th or July 10th, but you'll know when you get to do this. And that duration is 8 weeks. I put things in there so you'd have something to fill in there, okay? So the purpose of this report, this is the after action report for COVID-19, is to analyze event results, identify strengths to be maintained and built upon, identify potential areas for future improvement, and support the development of corrective actions which will guide future emergency preparedness initiatives to advance overall emergency preparedness within our clinic. That's why we're doing this. We've got to learn from this event, and of course we all are. So again, you're going to have a write-up on what COVID-19 is. I won't read that to you. If you have a television, you're getting a whole lot of information at this point on what COVID is, where it came from, what a pandemic is as a global outbreak of a disease. Signs and symptoms and severity, you're going to write that up. You can just copy and paste this, folks. Just make this your own, but on your clinic letterhead. But this is what, and I'll tell you, as I wrote this part, I wrote a couple weeks ago about the where this came from in Wuhan, China, and we really don't have all the answers to that at this point, do we? Did it come from that lab, or did it come from that animal place? And there's a lot of discussion on that. But we have what the symptoms are, how long it's going to last, 2 to 14 days. It's pretty obvious that most people are not getting sick, and of course those get sick, get dreadfully ill, and even die. So we're going to have a timeline in this. And again, you're going to make your part of this. What I found fascinating when I put this together, I'll share that with you in a sec. January 22nd this year, CDC confirmed the first case of COVID in the United States, right up the road from you folks, a neighbor of yours. January 30th, the World Health Organization declared the outbreak a public health emergency of international concern. January 31st, HHS Secretary Azar declared a public health emergency in the United States due to COVID-19. March 8th is when your Governor Kate Brown declared a state of emergency. When I looked at this, I was like blown away by that big gap there. What the heck happened in February? Very, very, very interesting. You may have some things that happened in your clinic during that time, and you should note those. When did you start really getting involved in this COVID-19? March 11th, the COVID-19 outbreak was characterized as a pandemic by the World Health Organization when it went to, I think, 164 countries or something like that. Could be more. March 13th, President Trump announced a proclamation declaring a national emergency concerning the novel coronavirus disease. So these are the dates that count. The last piece of the timeline is going to be the end of this thing, and you'll have to wait to see when that's going to be. So in your after action reports, you're going to have an executive summary. This event in the first half of 2020 occurred as a result of the coronavirus from Wuhan, China, which resulted in a worldwide pandemic. The event began for ABC Clinic, your clinic, on March what? Or was it February something? But it's going to be February or March 2020. You fill in the date. Our emergency team was composed of, and who's the name of the staff people in leadership in your clinic? And we're going to fill this in and type it up. Now, staff training is a key part of any emergency preparedness, and what did we do? So we probably started off, and you're going to fill in the dates here. What is COVID-19? And we trained the providers and the staff on what? To educate them on the threat, on signs and symptoms. We then had to move to PPE. What is PPE? How do we properly use PPE? When do we need PPE? The most important piece to that is how to properly remove PPE. If you don't take a gown and gloves and mask off in the proper order, you have every right to think you're going to get self-infect, and we don't want that to happen. So we educated the providers and the staff on that. We can use the CDC video on the proper use of PPE if you wish. Patient screening was the next training, and providers and staff. Implementation of the patient questionnaire. The door sign. When did we put that door sign up? The importance of stopping symptomatic patients at the door. Go back to the car and call. We'll see you out there. We'll come out. We'll take your temperature. We can take your blood pressure. We can ask you some questions. We can get the general feel for how you're doing and send you either home or if you're acutely ill somewhere else. We don't want you to come into the clinic. Phone screening. We're going to educate the front desk staff and nursing. How to question patients. Good idea to do some role playing on that. Updated protocols. What have we changed? What's different in our clinic for all the providers and the staff? Talking about triage. How are we managing our patient population? How are we keeping healthier patients away from anybody that's symptomatic? All these things came into the training. Testing and reporting protocols, that would be by your state. You don't test, but where do you send them for tests? How do you know where they're supposed to go? And what are the CDC testing protocols? And this is something that you'll be doing again in the weeks to come because it's changing very rapidly, very rapidly. And most recently, finally, telehealth being the distance site for Rural Health Clinic. We did it before we got the final approval because we had to. Now we can get paid for it. Backdated, which is awesome. Hopefully you have the great documentation for that, and that would be training the providers. Most importantly here is HIPAA. How did when we're not using the bona fide telehealth equipment yet, we must notify patients that this is perhaps a possible, somebody could hear or listen in or whatever when we're talking to somebody on FaceTime or something like that. There are HIPAA considerations here, but we just must notify our patients at this point because we're covered under a waiver. You do it how you need to do it right now for the staff. And I want to thank Patty Harper for this. I did adjust it a little bit. I said this is a pretty well combination of three people, but Patty Harper of InquaSeq put this chart together, and I thought it was really worthwhile. But this is going to go into your after action report for COVID-19. Training logs are key. That last slide showing all that training really isn't any good unless we have a log. And you can do it two different ways. You can have one date, February 28th, we did PPE training, and then all the names and then their signatures, or just a big old page with names and signatures. It doesn't matter. We want a piece of paper that shows if there's 10 people in their clinic, there's the 10 names, the date they trained, on what they trained, and you're good to go. And that's pretty true of all things training. So what actions did we take? Staff screening, temps as they enter the building, question staff about symptoms, ask about possible exposure. Anybody you know sick. This is patients and staff. Identifying staff at risk. Anything else that you can think of, what actions you took. That's why I say keep your notes, write them down. As a result of activation of our emergency plan, the following modifications or restrictions in services were implemented, including cessation of services, relocation of services, reduced hours, use of telehealth and e-visits, and then relocation of providers to the hospital. CMS also waived the 50% requirement till the end of the emergency for your NP or PA to be in the clinic. So if they're either furloughed because of lack of patients, or what we've heard more importantly is they're pulled to the hospital to help, to work, and so you don't have them in the clinic. And that's allowed at this point. Nobody's looking at 50% on-site times through this emergency until the emergency ends. Of course, that'll go back to how it is now. What other actions? PPE, supply inventory. Following actions were performed related to securing PPE, medical supplies, lab supplies, other necessary items needed to remain operational. What was our initial supply on hand? We had 50 masks in the whole clinic, and we're going through them like water. What are we going to do? We're going to order. We're going to order gowns. We're going to order more alcohol-based hand rubs, which is, of course, in great demand at the moment. So what's going to put in our plan to say, should we have another, let's call it an epidemic of some sort, that we need more of that in our clinic? We are not really fully stocked on that. The challenge here, I spoke to a very large system yesterday who has spent more on PPE in February into March than the entire year of 2019 for one hospital system. And that's a huge, huge burden, which is causing great pain in a lot of ways, obviously. We hope that we all get some relief. You should be thrilled about what passed last night, and that is that rural health clinics are actually going to get some money, which is really, really exciting. Watch the NARC website for information on that. It's out there. Okay, so on the after action report analysis, areas of improvement: need to order extra supplies such as mask and hand sanitizer. We need to minimize things in the waiting room. Perhaps we didn't think to take away anything that couldn't be cleaned. Magazines, plants, anything, make it sterile. So you can go out there a couple times a day and you can wipe things down, and separate chairs, take a few chairs out, and give it some social distancing. Need for more screening of clinic staff temps in the morning. I don't know what your areas of improvement are. These are just a few that I came up with for this analysis. So event successes, write about it. Our staff immediately began calling patients instead of visits to decrease exposure. Great success. It's happening across the country. Put it in your after action. This is a success for you. Some staff sent to hospital to assist with sturge. What are your major strengths? Enter the top 3 strengths of your emergency plan. Staff training conducted on infection prevention, plan to triage patients who come to the clinic, put the sign on the door. What have you done? Brag about it in your report. That's what this is all about. Not just the things we need to improve, but things that we've done well, and you have. What unanticipated issues arose during this experience, I'll say? What gaps were identified? What are some high priority issues that should be addressed? And what are some new ideas and recommendations for improvement? All of this in your after action report. So you can put it in a chart, your improvement plan. So we observed that we lack supplies. We're going to recommend we keep more on hand. So we've ordered them. We don't have a plan of correction yet because we're not on a survey here, but we have a start date of June 1, and we'll have plenty of supplies by July 15th, just an idea on how to put this together. Do we need more staff training? We're probably all going to need more training in telehealth, and of course that's the one thing, one of the biggest things that we hope will stay after this. And it still requires a law change, but perhaps this will show the Congress that we need to be the distant site in rural health clinics, and we need a good pay structure for it. And we are working toward that with and on the Hill. And the staff report reviewed with the staff. So this is after you've written this report. We're going to go back and review it with the staff. They're going to give an assignments. and there's an attendance log at every one of these meetings. So you're good to go for that whole year. Now, this last piece, and I'm going to show you what I have here for a moment. I found this yesterday. This is a U.S. government tabletop, and they call it a TTX, Pandemic Stimulation 2008114. You can find it on this website. This is a fascinating piece. I wouldn't dream of taking the time to read this to you, but you will have this today, and you can use this for your own edification and pull things out of here as you go on different tabletops. Rhonda, before I roll through this, any questions?
No, there are no questions.
Well, you guys are just too good up there in Oregon, huh? Okay, so this is now this blew my mind because this is a downloadable tabletop exercise that the federal government wrote last year. It almost gave me the creeps because look at how it starts. I didn't fill that in. I typed this. I was just amazed. So they did a report on a mystery killer disease in China. Unbelievable. I mean, the facts don't match. Obviously, none of this matches, but that just was kind of really strange. And so it goes on all the way through. Week 1, report by the government in China to the World Health. Week 2, heightened media interest. Week 3, combination of a hybrid virus efficient to human transmission. Actions taken by the government, close the border. I mean, you can't make this up that this was last year. I had to look at it 3 times to verify that. Cluster outbreaks inside of the containment zone. What kind of questions are we asking? It's a great exercise. Again, we don't have time to read all this. It's very detailed. Week 5, the virus spreads outside Wuhan, if you will. Week 5 continues. The World Health Organization has warned of the possibility that this could escalate into a full-scale pandemic. This is 2019. This is not 2020. Week 6, the spread to outside China and other countries. Week 7, it's in our country. Week 8, further outbreak in U.S. cities. It's just amazing to me. Week 8 continued, the messages that are out there for the public. How do we notify the public? What do we do? Public anxieties by week 9. Week 10, travel restrictions. We had those way earlier, thank goodness. Week 11, stockpiling of basic commodities. We've seen all of this. It's just amazing to me. I think you'll be fascinated if you have time to read this thing at some point. You'll have it later. Then week 12, World Health Organization declares a pandemic, and that's it. So it just was fascinating to me how that came out of last year, and that's on the government website. You will find it. I gave you that link. So again, I want to thank Patty Harper for helping with this. She put a number of those things together. She does a great job. If you don't know her, you should. She can help you with a lot of things rural. Any questions, Rhonda?
No, Kate, there are not any questions at this time.
Okay. Well, that's all I have today. If you have other questions, you have my information there. You can call or email. Be glad to help. We appreciate what you're doing out there, and I wish you would all be safe.
And just to let everyone know, as soon as the recording is available, that we will post the recording and the slides on the Office of Rural Health website. And I will also be sending out the survey. So if you have time, please complete the survey so that we can continue to improve our webinars and bring you the educational information you request. And thank you so much for attending today. And I'm sure it was helpful. You're wonderful. Thank you.
Thank you. Bye-bye now.
Bye.